this was a very posteriorly placed colloid cyst. So this was my trick number 3, that when you have a very posteriorly placed colloid cyst, you have to reach the root of it before removing it. So I'm going to be very fast here and stop it. This was my trick number 3. And then my trick number 4 is that small colloid cysts with thick contents can be removed endoscopically. Do I have enough time to run the video or no?
If you want to just summarize the highlights.
Sure. Okay. So I won't run the video, but this picture actually showed small colloid cysts with very thick contents can be removed endoscopically. Trick number 5 is that if the ventricles are small and the colloid cyst is also small, then you really have to make sure that you choose the right procedure, an anterior transcallosal versus an endoscopic removal. I always give the family this idea that I'm going to try to remove it endoscopically, but if I'm unable to, then I have to convert it into an open procedure. Mostly what happens with small ventricles is that the moment you enter, the CSF removes and the ventricle collapses and you are unable to see the ventricle and the colloid cyst then. And that's the reason you should always be ready to convert it into an open approach. And this is one of the cases in which there's small ventricles and a very small colloid cyst here. Trick number 6 is that if the ventricles are small and colloid cyst moderate size, then endoscopic removal is possibility. So always give endoscopic the first try and then the open procedure. Now I'm not going to run the video because of the time is not short. This was another video in which head of the caudate was actually in my way. That could also be a problem in these kind of cases and it makes it a little bit more difficult, and that's why you should be readily turn it into an open procedure. This was a case in which there was a redo, this was a redo case, and you can see there were a lot of adhesions on the head of the caudate and the fornix over here. So again, makes it difficult, convert it into an open procedure whenever you want. This was trick number 7, in which I actually used a small feeding tube where a suction to actually remove the contents, because the contents were not solid but very oily. And so you can easily remove it. This is my trick number 7. And then the trick number 8 I wanted to tell you was that not all colloid cysts are colloid cysts. Sometimes this tumor, this video would have shown you a tumor instead of a colloid cyst. And the conclusion, so I've got 8 tricks that I've gone through. One is, I'm going to just summarize it very quickly. The first trick is that you actually use the longer CSF path. The second one is you use neuronavigation. Then the third one is that the ventricles, depending on the size and the ventricle size and the colloid cyst size, you choose whether you want to do endoscopic or closed. You can use, if the ventricles are small, not always you can do open, but you can do endoscopically by hydrostatically enlarging the ventricles. You can also use small feeding tube to remove the oily contents. And if it's a solid content, always convert it into an open procedure. So in conclusion, endoscopic colloid cyst removal is safe and effective. Conversion to an open procedure is not uncommon, 17% by some papers, but can be executed rapidly and is usually a consequences of large and a firm tumor or the tumor that are adhered to either the veins or on the fornix and the other structure. The procedure is a bit difficult, I would say. It requires a degree of experience in endoscopy. Thank you so much. I hope I didn't take too much extra time.
Aneela, that was fantastic. I think everyone can really appreciate the skilled technical expertise that's required to manage these tumors intraoperatively. We'll hold on questions and move along here. Dr. Abhidha Shah will be giving a talk next on the Papez circuit and limbic system by fiber dissection.
I think I didn't see the speaker on the panel. Dr. Iqbal, is she here? Is Abhidha is here? I didn't see her.
I think we can go to the next talk. Let me just contact her.
Yes, please. So
she's not in, so go on to the next talk.
Yes. So Hello, everybody. And I just want to say thank you to the Pakistani Society of Neurosurgery and to the organizers and, of course, Professor Salman and Dr. Nur Iqbal. It's really a great pleasure to join this webinar and with this theme, which is Future in Neurosurgery. And I'm convinced that future in neurosurgery are women. And I'm proud to be here with so talented women giving talks, which are very interesting for education. We have scientific talks and we have also talks about mentoring and about managing a career, which are very important topics in education. So I think that we will move to the presentation of Dr. Maya Babu. Is she here? Yes. And she will talk about neurosurgical trauma. Dr. Maya Babu is Director of Adult Trauma in Mass General Hospitals in Pakistan. So you have 10 minutes, please.
Thank you. Can you hear me okay?
Yep.
Yes, we will.
Okay, great.
We are hearing.
Fantastic. I'm going to share my screen. Thanks so much for the very kind invitation. And just to update everyone as well. Here, let me click on this. Hopefully you can see my screen.
Yep.
Yes.
Thanks so much for the very kind invitation. And I actually just wanted to update. I'm actually at Cleveland Clinic, Florida now. I've changed positions down in the Treasure Coast area of Florida. But the topic that I'll be talking about is head trauma and ICP monitoring. And this is really meant to be a high-level overview. What I wanted to do was, because we had about 10 minutes this morning, really give a high-level summary of intracranial pressure monitoring and where we stand. And obviously there have been many advances and still ongoing research in terms of fancier monitoring systems, whether it's brain tissue oxygenation, having to do with perfusion, having to do with seizure monitoring, probes, etc., deep wires, etc. But instead of focusing on the technological aspects, because obviously these aren't universally used or researched, what I wanted to do was focus on the clinical side, which I think is relevant for all of us as neurosurgeons as we care for patients and try to make decisions based upon what information and tools we have at our disposal. So with that, so I was going to start with a quick case summary. This is an 18-year-old patient who actually suffered a gunshot wound to the head and to the chest. When he arrived to us, he was a GCS of 5, and this was a case actually from Southern Florida, not from where I am currently, but when I was at an institution more south of where I am currently. When he arrived to us, he had significant extravasation of blood into his chest. He needed an emergent trip to the operating room with general surgery for an X-lab. His initial injuries, not surprisingly, when a patient comes in, they don't have isolated head trauma. He had polytrauma. He had a hemopneumothorax, as well as hematomas in his neck, left lower lobe collapse, rib fractures, etc. Initially, it was unclear to us whether he had a spine or a spinal cord injury. This is his CT scan, and you can see, obviously, bihemispheric injury. We can see shrapnel. We can see fragments slash hematoma on both sides, bihemispheric. And kind of the first question we had is what should be done? There's absolutely dogma that suggests, bihemispheric injuries have a high fatality rate. There have been some studies in the literature, some papers, doing a retrospective review of patients, especially military studies that have suggested that bihemispheric injuries, high fatality rate. But this patient was young, and obviously we don't want to just simply go with what the literature suggests. And so what we did was we initially placed an external ventricular drain, and the idea was not, necessarily to treat him in that way definitively. It was more as he was proceeding to the operating room with general surgery, we wanted to make sure, A, we had a monitoring system, and B, we had a therapeutic monitoring system, which an external ventricular drain offered. I know a lot of centers would have probably considered an ICP monitor alone. When he was in the operating room with general surgery, his thoracotomy identified a bleeding artery, which was ligated. So that, helped tremendously, obviously, with blood loss. Post-operatively, he went to our trauma intensive care unit. Several hours later, he was noted to have just intractably elevated ICPs. Obviously, we didn't have a good sense of an exam at that point, and there was really no appropriate way to obtain an exam. So what to do? I think in this situation, we have a patient, we're obviously, pulling out all stops, and the answer is you proceed to the operating room. And so what was done was a left-sided decompressive hemicraniectomy for hypertension at that point, intracranial hypertension, but really to help with this initial injury. So this is the initial procedure that was done. And so just to step back, when we think about monitoring, obviously this case poses a bit of a unique challenge in terms of why we would monitor, how we would monitor. But I just wanted to give you a very high level overview of the way we think about intracranial pressure monitoring. And obviously this is not without the bells and whistles. This is just with ICP readings. Now, when we look at the guidelines, the Brain Trauma Foundation guidelines, we have a sense, if we read the guidelines in the fourth edition, for instance, how exactly we address or deal with these types of patients. Obviously, we use GCS score as our initial guide. We use their presenting head CT as an initial guide if there's a hematoma, contusion, something that doesn't appear to be immediately operative, but is concerning, essentially prompts monitoring. Now, we also do monitor, and there is some wiggle room, frankly, within the guidelines in terms of severe TBI, even if you have a normal head CT, if the patient meets several parameters. It's important to have, some thought at least to whether or not you think monitoring is important. Interestingly, up to 50% of patients who develop increased intracranial pressure may have a normal admission head CT. And that makes sense. I think the more we learn about trauma, the more we realize, our tools are an adjunct. And that's really, I think, the main thrust of my talk. I didn't want to get into the fancy technology with pressure monitoring and all these things, because ultimately these are all adjuncts for your clinical guidance, your clinical judgment, and your assessment of the patient. And we certainly don't want to rely on our technology to be our sole driver for whether we intervene or not. So there's also been the Milan Consensus Conference, which suggested that monitoring, could be used in other situations. So for instance, diffuse axonal injury, which we often, at least initially, didn't think of as an opportunity for monitoring. Certainly bifrontal contusions and non-comatose patients, and post-surgically, because that's been an area of controversy within trauma. If you think about it, after you've done a hemicranie, you have this big flap as a defect. And there is a school of thought that you can use that flap, and whether it's full, it's soft, etc., to help guide you in many ways, especially if you're in a resource poor setting or you just don't have access to reliably to monitors, which can be really throughout the world. It can be a challenge. So in the post-surgical setting, it was interesting to actually think through whether monitoring even made sense. And the Milan Consensus Conference went on to suggest a few other parameters. And several other papers have looked at, considering monitoring if you have patients with large bifrontal contusions, irrespective of their neurologic condition, which is interesting. ICP monitoring when there's a sedation interruption. So some folks have suggested that, well, if you have to sedate a patient for a period of time, you should have monitoring on board. I don't think that's a widely held statement or a belief. And ICP monitoring can be useful when you don't have a reliable exam. And again, I think that the challenge is We do so much at the bedside. In the ICU, patients are heavily sedated. Obviously, they have multiple injuries, oftentimes not just an isolated head injury, and patients will have respiratory issues, ventilatory issues. So I think it's always important to really step back and think about why you can't get an exam before proceeding with a monitor, and then also think about what monitoring will provide you. Is it going to help trigger your decision to go to the operating room? And if so, kind of what is your thought process for doing that? Because I think the challenge is these tools are all meant to help us. They're not meant to be our primary source of information. So I'll just quickly go through this since I only have a minute or so. ICP monitoring is recommended after a craniotomy by some folks in the literature, specifically if you have concerns about ongoing hypoxia, hypotension, there's any baseline pupillary abnormalities, and if there's subsequent surgeries. Again, oftentimes anesthesia and future anesthesias might be a trigger for it. This is not universally held, but this has been noted in the literature as a potential role. And frankly, you know, as we were talking about before, monitoring in the setting of having your bone flap off, I think is still questionable. And certainly there have been a few papers that have tried to look at this. It's interesting though, the number of centers that still will routinely place a monitor even after a hemicranie. So monitoring strategies, again, I think imaging has become in most centers a primary monitoring strategy, obtaining a repeat head CT if there's any concern. Invasive monitorings, obviously we have multiple types of monitors now, some experimental, some more routine. We talk about the interparenchymal monitors versus external ventricular drains. Obviously some benefits. External ventricular drains tend to have a higher hemorrhage rate associated, but obviously if placed properly can provide therapeutic advantage as well. And really what monitor to use and whether to use a monitor is a decision. It's a decision based upon several factors. The underlying etiology for the patient's head trauma, any coagulopathy that might be occurring, any hydrocephalus concerns. And there's also non-invasive monitoring that I think is very interesting and tremendously exciting. Optic nerve sheath diameter we've used in patients who haven't felt comfortable placing a monitor for various reasons. And that can actually be tremendously helpful. Now, again, it's an adjunct. It doesn't replace our clinical judgment. There's also transcranial Doppler ultrasound, which can be used at the bedside. These are all based with ultrasound, based upon ultrasound, which can also be, nowadays we can have a little hookup to our cell phones and can be able to do this at the bedside. So I think that from a applicability standpoint is very exciting. And then obviously when we talk about acute elevations, we talk about hyperosmolar therapy, and if intractable, we do talk about surgery. Now I mentioned hypothermia here, obviously very controversial, not part of the guidelines per se in terms of a recommendation, but certainly there are still, I would say, studies ongoing that have tried to use it, you know, in some form or fashion with varying protocols, but certainly not, I would say, a practice that is used widely. Now, some of the literature suggests that there's, you know, with aggressive care, which could include ICP monitoring, you may see outcome improvements. However, I think overall, there's no good data to suggest that ICP monitoring in and of itself, you know, leads to improved outcomes. We obviously want the best outcomes for our patients. So it's a complex decision. And these patients need a lot of, I would say, observation and thought put together in terms of putting their entire picture together, not just relying on what the monitor is telling us. And I'll just give you a quick follow-up. This is my patient, used with permission. He thankfully survived after a protracted course in the ICU and did quite well. And so just a plug to say, please don't give up on anyone. I think they have the chance to pull through, and we certainly want to be there for our patients and help guide them as best we can, hopefully towards survival and recovery. Thank you.
That was excellent, Dr. Babu. There's a question in the chat around intractable elevated ICP and how you define that and what's the cutoff for when surgery is indicated. I know you kind of already spoke about the complexity of those considerations, but can you speak a little bit more to specific ICP levels and when at least your group is considering surgery?
Absolutely. So in general, you know, if the literature suggests 20, and there's nothing magical about 20, sometimes it's 25 millimeters mercury. It is different for pediatric patients. Yes, I was just about to say that. Depending upon the age, it is different. So, you know, and the age ranges vary as well, below 18. So I'll just kind of talk about above 18, below 18, because, you know, I think that there are gradations, and your threshold for concern, frankly, in a child should be higher regardless. In general, we use 20. Sometimes we'll extend that to 25 if we're, again, depending upon the parameters and where we think the patient may normally live in terms of their pressures. And then I noticed too, ultrasound. Yeah, there's some newer setups with the ultrasound, with your smartphone, where you can actually put on it's almost a separate piece that can affix to the phone, and that can provide a fairly high quality image. Again, I didn't want to, you know, peddle any sort of specific technologies or talk about what's in existence. I think it's an exciting area in the future, especially if we can use it as an adjunct for our decision making.
I think that we will take other questions at the end, as it is mentioned by the organizers. So Dr. Zarina, could you introduce Dr. Abhidha Shah? I see that she is with us now.
Sure, wonderful. Thank you for being here with us. Dr. Abhidha Shah is an assistant professor in KEM Hospital in Mumbai, India, and she will be joining us to give us a talk on the Papez circuit and limbic system.
Thank you, Zarina. And I'm sorry for being late because I had some issue joining in. But anyways, I'm here now. I'll start sharing my screen. Okay, can you see it now?
Yes.
Okay. So I'm going to be talking about a little difficult subject. And I have chosen this topic because it's not very easy to understand this topic just by reading from the textbook. Once you have a 3D image in your mind, it will be very easy to understand this. And it is absolutely essential for us to understand this anatomy when operating on intraaxial tumors. And let's start with it. So I'm going to discuss the limbic system and the Papez circuit. And I have done this dissection using fiber dissection techniques in my department. So we recently published this paper where we have discussed the fiber architecture of the whole cerebral hemisphere. And why is this important? Basically, if you damage a cortical area, because of plasticity, some other cortical area might take over, or you might just get away with it. But if you damage any of these fiber bundles, it's going to be a permanent deficit, and you're not going to be able to come back with it. So a lot of these fibers are part of the limbic system. You have the cingulum here, you have the uncinate fasciculus, you have some fibers of the corpus callosum, the anterior commissure, the hippocampal commissure, and the fornix. And all these problems, damage to all these fibers will cause so many deficits. So what we did is we classified white fibers of the brain into 5 layers. The first layer is the superficial group, which is the short association or arcuate fibers. The second group was the middle group. It consists of mainly long association fibers. So you have the superior longitudinal, the arcuate fasciculus, the middle longitudinal fasciculus, the uncinate, the IFOF, and parts of the sagittal stratum. The deep group was the one that was in relation to the ventricles, where you had the fornix, the stria terminalis, the stria medullaris thalami, and the medial and lateral longitudinal striae. And the central group were all the commissural fibers. They basically occupy a central position in between both the hemispheres. And you have the corpus callosum, the anterior commissure, posterior commissure, the habenular, and the hippocampal commissure. And basically dividing these groups into 2, into a medial part and a lateral part, is a vertical layer of fibers. These are called the projection fibers. and they're constituted of the internal capsule and the thalamic radiation. So let's look into this. So this is a medial aspect of the hemisphere. I'm showing the medial view because most of the limbic system components come in this view. Then I will show you from inferior also. So you have this yellow circle, which is the short fibers or the short arcuate fibers, association fibers. This is the middle group of long association fibers. So you can see the cingulum here, you can see the SLF here. This is the red circle is the deep group. These are fibers mainly in relation of the ventricle, and all the limbic system fibers come within this group. The green circle is that of the corpus callosum, and this orange circle is the vertical layer or the projection fibers. So now what is the limbic system? This is the most complex and least understood system. Limbus basically means a border or margin, and I will show you how this is a C-shaped system. Basically, it was first defined by Thomas Willis, where he called it as limbus. Then Broca called it Legrand limbic. Then MacLean included some cortical, subcortical fiber connections and their fiber connections in the limbic system. And Nauta extended the limbic system to include the midbrain. So now, Papez circuit. James Papez first postulated that the anatomical basis of emotion was found in the thalamus, the anterior thalamic nuclei, cingulate gyrus, hippocampus, and its interconnections. We're going to look at each of these now. And we had studied this way back in 10 years back, where we published this, where we studied the whole system by fiber dissection techniques. And I'm going to review the anatomy now. So basically, the limbic system is part of the old brain. It is composed of gray matter and white matter. So the gray matter constituents are the hippocampus, the amygdala, the hypothalamus, the basal nuclei, the cingulum, prefrontal cortex areas, and some midbrain nuclei. And the white matter components are mainly the cingulum, the fornix, the anterior commissure, mammillothalamic mammallotegmental tracts, the striae terminalis, the dorsal longitudinal fasciculus, and the medial forebrain bundle. So what we did is we froze and formalin fixed our brains, and we used the Klingler method to do the dissection. The tools were basically ice cream spoons, which were curved into various sizes and shapes so that we could do the dissection. And for the limbic system, you have to start from the medial aspect. So now I'm going to peel off a layer by layer and show you all the components of the limbic system. So this is a view which we are all very familiar with. You have the whole corpus callosum here on the medial aspect of the hemisphere. What you see on top of the corpus callosum, you have a thin layer of gray matter that runs over the entire corpus callosum, and this is the inducium crisium. What is it? Basically, it is a continuation of some fibers of the fornix. When the fornix develops, it is a C-shaped structure that develops. So the dorsal portion of the fornix does not develop, and the hippocampus does not develop as well as the inferior portion. So some vestigial fibers remain, and that forms a gray matter here, and that is the inducium crisium. Within this gray matter, there are two longitudinal striae. These are called the medial and longitudinal striae of Lassinci. So when we go further, you see the medial aspect of the hemisphere. This is the anterior commissure. This is the fornix. This is the choroid plexus in the choroid fissure. This is the thalamus, and this is the corpus callosum. So what we do is we remove the first layer. First of all, you should understand that the limbic system is a series of Cs. There are a series of rings within each other. So you have this first outer ring that is of the cingulum. Then you have the fibers of the inducium crisium and the lateral and medial longitudinal striae that run across in a C-shaped manner. Then you have another C running close to the ventricle, and that is the striae terminalis. And then you have the C of the fornix that goes all the way to the hippocampus. So it is basically a ring within a ring. If you understand this, you start understanding the anatomy. So the first fiber that we see here is the cingulum, which is beginning here in the subcallosal area, running above the corpus callosum all the way behind. In this region, it is known as the isthmus of the cingulum, and it goes down to end in the entorrhinal area, where it is called the radiation of the cingulum. So this is the connection, first connection of the limbic system that you can start seeing here. There are also some fibers from the cingulum that go to the cortex. So this is how the cingulum communicates with the higher order of the brain. So there is a parietal communication, and generally there is also a frontal communication. As you can see in this image, this is the frontal communication of the cingulum. This is the parietal communication of the cingulum. This is the corpus callosum. This is the caudate head, and this is the thalamus. This white fiber that you see running here is the striae terminalis. This is the one that runs between the caudate and the thalamus, and it is basically connecting the amygdala to the septal nuclei. Now, what are the septal nuclei? The septal nuclei are not something that are found in the septum pellucidum. They are found in this area. If I go to the previous image, this area here, that is just below the corpus callosum, consists of the paraterminal gyrus and the subcallosal gyrus. And this is the location of the septal nuclei. So the striae terminalis basically connects your amygdala all the way to the septal area here. Moving on, when you dissect further in this region, you start seeing the mammillary body here. When you remove the gray matter of the thalamus, you will start seeing the mammillothalamic tract as it goes up to the anterior nucleus of the thalamus. This is the column of the fornix. So again, mammillary body basically gives two tracts. This is the mammillothalamic tract as it goes to the anterior nucleus of the thalamus, and this is the mammillotegmental tract that goes down to connect to the tegmental nucleus of Gooden. So this is the two gyri that I was talking to you about. This is the paraterminal gyrus, and this is the subcallosal gyrus. This structure here is the hippocampus, and this is the parahippocampus. We will see that as I go further. So now let's go into the parahippocampus. Now you see this parahippocampus here. Basically, it is coming on the medial aspect of the cerebral hemisphere. The parahippocampus turns. Where it turns, the turn is called the subiculum. When it turns, the inner part of it forms the hippocampus. And as it turns further, you will have the dentate gyrus. So as you go further, this is what you see. This is the hippocampus. There is a white fiber that is forming on the surface of the hippocampus. This is the fimbria and goes on to form the fornix and the columns of the fornix ending in the mammillary body. This is the mammillothalamic tract. This denticulate structure that you see here is the dentate gyrus. So this is again the whole Papez circuit that you can see here. You can see that this is the fimbria that is going, hippocampus, fimbria that is going to form the fornix, the body of the fornix, the columns of the fornix, the mammillary body, the mammillothalamic tract, anterior nucleus of thalamus. And as you go further, there are fibers that come out from the anterior nucleus of thalamus. So this half of the corpus callosum has been cut. And if you lift, you see the caudate head. And if you lift this caudate head up, you will see fibers radiating from the anterior nucleus of the thalamus. And these are the components of the anterior thalamic radiation, where they mingle with the internal capsule. And this is your vertical group of fibers. And they go ahead and join the cingulum. So this is the anterior thalamic peduncle as it goes ahead to go ahead and join the cingulum. So here you have the whole Papez circuit that is dissected in situ. To revise, this is the hippocampus, fornix, fimbria going on to form the fornix, mammillary body, mammillothalamic tract, anterior nucleus of thalamus, anterior thalamic radiation, cingulum, and the cingulum coming back to end in the hippocampus and as the radiation of the cingulum. So this is the in situ dissection of the Papez circuit. And then we decided to get it out. And we have an additional component here that is a part of the limbic system. So this is the Papez circuit you can see dissected outside with all its components. And this is the olfactory tract and striae, which is also a very important component of the limbic system. So this is the major, Papez circuit forms a major component of the limbic system, but there are a few other structures that we should know about, which are seen on the inferior aspect of the hemisphere. So this is the inferior surface of the frontal lobe, the orbital surface. This is the gyrus rectus, the olfactory tract divided into the medial and the lateral olfactory striae. So the medial striae, both of these border the anterior perforated substance. The medial striae go on to join the para-olfactory and paraterminal gyri, and the lateral striae goes ahead to join the amygdala. So this is the connection. And this fiber bundle that you start seeing here is that of the anterior commissure, which as you dissect further, you will see this is the entire extent of the anterior commissure, which is a bow-shaped structure, which has two extensions, a frontal extension and a temporal extension. The frontal extension connects the olfactory nuclei of both sides, and the temporal connection goes laterally to form the sagittal stratum. as I will show you now, this is the anterior commissure. This is the inferior aspect of the temporal lobe. And when you see it from the lateral aspect, this is the internal capsule and the anterior commissure joining the optic radiations as part of the sagittal stratum. The last component is the inferior lobe of the inferior surface of the hemisphere to see components of the limbic system. So this yellow structure here is the parahippocampal gyrus. It is intimately related to the brainstem here. This portion of the parahippocampal gyrus is the uncus, where you can see how closely related it is to the midbrain and the posterior cerebral artery, which is very important while performing epilepsy surgery and medial temporal tumors. So as you start removing the gray matter from the inferior surface, this is the gray matter of the uncus. First fiber bundle that you see is the radiation of the cingulum here. This is the ending of the cingulum that you saw from the from the medial aspect. So these are the fibers which are more clearly seen now. This is the radiation of the cingulum. As you peel off this layer, you will see the ependyma of the temporal horn. Once you peel this off, you will see the magnificent structure that is the hippocampus. You can see the head, the body, and the tail lying in the temporal horn of the ventricle. This gray matter structure here is the amygdala. This is the choroid plexus. And as you deflect the hippocampus more inferiorly, you will start seeing another important fiber, and that is the fibers of the Mayer's loop. So you have the optic tract coming here in the ending in the geniculate body, and from here the Mayer's loop begins to go into the roof and the lateral aspect of the temporal horn. So this is the Mayer's loop here, and this is the lateral aspect of the hemisphere, where, as I said, the anterior commissure comes in and joins also to form the sagittal stratum with the optic radiation. And the last structure that we can see here is the fornix, the hippocampus as it becomes the fornix. This is the head of the hippocampus, body and tail ending here. This thin layer is the fimbria going ahead to form the parts of the fornix. Both the fornices communicate with each other here. This area is that of the hippocampal commissure. You can see this beautifully dissected specimen in this. And why is all this relevant? The most relevant aspect or the most important surgical application of the limbic system is when you're doing temporal lobectomies and epilepsy surgery. So this is your lateral aspect of the cerebral hemisphere. When you start doing a corticectomy in the middle temporal gyrus, you will see the hippocampus here. Here you can see the hippocampus that is turning here into the tail. And at this region, you will see the amygdala. So this is the portion of the amygdala and the hippocampus and the temporal lobe that you remove during a amygdalohippocampectomy. So here you can see the coronal section showing the head of the hippocampus here. And this image shows the relation of the amygdala, how amygdala is closely related to globus pallidus. So if you see a hippocampus here, this is the region of your amygdala. If your incision goes beyond this, you will straight land up into the globus pallidus and cause very bad deficits. So it is important to remember this demarcation. This is the olfactory component of the limbic system as it joins here, going to connect on to the amygdala. And these are fibers of the sagittal stratum. You have here the IFOF, which is the first layer. Below that will be the anterior commissure, and below that will be the Mayer's loop. And this is how they're related to the hippocampus. So when you're doing a temporal lobectomy and you enter the temporal horn in not a very good location, you're going to damage this fiber bundle, which is going to cause a pie in the sky deficit. So this is how it is related to the hippocampus. So basically there is an area here, in this area, when you enter the temporal horn from this aspect, there will be no Mayer's loop here, and it is safe to dissect and then go on to do a amygdalohippocampectomy from this region. And this is how it is related to the internal capsule.
Dr.
So just
Shah, I'm just going to ask you to just summarize very briefly here.
In 2 minutes, I'm done. So this is the inferior, just a operative specimen view. This is how you see the hippocampus. And this is how you see the amygdala. And this is the portion that you will remove with the uncus. And this is where you have to be careful with the cerebral peduncle. So these are the various connections of the limbic system and the Papez circuit. And these are some connections of the limbic system to the diencephalon, to the telencephalon and the mesencephalon. Because of lack of time, I won't explain this. And this is again an image of the Papez circuit. And thank you very much.
Those are terrific. I'm going to vote for an entire separate webinar of just reviewing that anatomy. Those are gorgeous dissections. Thank you so much, Dr. Shah.
Thank you. Thank you. I had to hurry up because, you know, this takes time, but I know I just tried to finish it quickly.
Thank you, Abhidha. Thank you.
All right, I think I am actually presenting next. I will just screen share here. All right. Can you see my screen?
Yep.
Okay. My fellowship training was in peripheral nerve surgery. So I do primarily spine and peripheral nerve surgery. I trained with Eric Zager, Raj Midha, Rob Spinner during my time at Penn and away from Penn. And then I joined the faculty thereafter. And as I said, my practice is primarily spine and peripheral nerve. So I'm taking the opportunity here to go through a couple of quick cases that highlight some of the considerations around resection of peripheral nerve sheath tumors. So the first case is a 61-year-old gentleman who has a 10-year history of painless, slow-growing mass on the left posterior medial ankle, progressive numbness in the plantar aspect of the foot and toes, no history of NF1. That's something we always think about as peripheral nerve surgeons, as NF1 patients have a high tendency to undergo malignant transformation of their typically benign neurofibromas. And this gentleman had an intact neurologic exam with the exception of diminished sensation in the foot. So you can see here on his MRI a heterogeneously enhancing mass located on the posterior medial aspect of the ankle. So as peripheral nerve surgeons, we get to operate throughout the body, one of the great joys of my specialty. And so here we're essentially dealing with tarsal tunnel syndrome due to entrapment of the posterior tibial nerve because of this large tumor. So we went ahead and took him to surgery. You can see here, is tumor that is underneath the ligament that we typically transect during tarsal tunnel resection. And I'll go through in a couple of more cases some of the more specific details around the operative approach, but this is a patient who has an excellent recovery after resection of tumor and relief of compression of that posterior tibial nerve. This is a 78-year-old lady who had presented with groin pain and perineal pain. It was actually going on for quite some time. And at the time that I saw her, she didn't have frank incontinence, but she did have urinary frequency. Again, no family history of NF1. And her neurologic exam was otherwise normal. So you can see here on this sagittal MRI that there is a in contrast enhancing tumor located at the level of S2, S3. And this is only a midline cut, but it's really important to look at and study these tumors very carefully prior to surgery, especially when they are either intraforaminal or extraforaminal. I'm always prepared to go intradural for these tumors because you can sometimes have a dumbbell shape to it where part of the tumor is extraforaminal and part of it is actually invading the dura. And so in this lady, we took her to the operating room and did a partial sacral laminectomy. Oftentimes with these slower growing tumors, the bone is often modeled and really tends to be, at least at the level of the sacrum, very, very thin here, given and that sort of speaks to the duration of time that the tumor takes to grow. And so her tumor ended up being all extradural, and so we were able to resect it en bloc. You can see here the gross anatomy of the tumor. And this is her post-op MRI showing an excellent decompression of the fecal sac at the sacrum. Interestingly, her tumor pathology proved to be a low-grade malignant peripheral nerve sheath tumor. We certainly think about these tumors differently. When I think about red flags for MPNST, we're always thinking about patients that, one, have any predisposition, as in NF1, for example. Typically, malignant peripheral nerve sheath tumors tend to be very painful for patients, unlike benign schwannomas or neurofibromas. The preoperative testing for patients with MPNST is imperfect and is the bane of our existence as peripheral nerve surgeons. There are some adjuncts that we routinely utilize, including things like PET scan, MRI with DWI sequences can be helpful, but none of those are really pathognomonic. And you can have tumors that on imaging appear very well circumscribed, no risk factors for the patient, and come back with this type of pathology. So we're always sort of on high alert with this. Given her diagnosis of low-grade MPNST, she had an excellent resection with gross total removal of tumor. As you know, with MPNSTs, we do perform neurectomy in addition to just tumor resection, which is different than our operative approach to just resecting benign neurofibromas or schwannomas. In this patient, we did do neurectomy at the time of surgery. I ultimately ended up getting her fractionated radiation in order to treat the operative bed, however. And she has done quite well. She's 2 years out from her diagnosis and doing very well. This is a 57-year-old lady who has a very interesting history of intracranial schwannoma, who also incidentally had a history of low-grade lung cancer. She is a ballroom dancer and presented due to electric-like shock sensations at the back of her knee and the popliteal fossa that she had noted when she was dancing. So you can see here a relatively small tumor, only a little over 1.5 centimeters, but in continuity with the common perineal nerve, and that was exactly her distribution of pain and discomfort. And so when I think about tumors for peripheral nerve sheath tumors, size is one component, but many of these tumors actually grow from sensory nerves. And so you can have very small tumors that are excruciatingly painful for patients because they're growing on the sensory nerve. And oftentimes patients are willing to take numbness over this excruciating pain that they experience due to nerve involvement and compression. So while in general, we typically will resect tumors once they reach something like 3 centimeters or over 3 centimeters, size isn't the only contributor to decision-making around when to resect these tumors. And certainly symptomatology trumps all sort of the clinical decision-making as to whether to resect these. In her case, we actually used one of our institution's ICG protocols, which is something that you may have seen in the literature more recently around resection of intracranial gliomas. And the idea here was really to see, can we get the kind of specificity that gives us information on tumor versus nerve fascicles. And, she was done as part of a research protocol, which I won't go through in detail, but you can clearly see the ICG lights up the tumor very nicely. Here is a fascicular sparing approach at resection of that tumor, where the ICG is now negative after gross total resection. This is another example. Again, small tumor, but again, when these tumors are growing on sensory nerves, they can be very, very painful for patients. She did excellently. Her tumor was a schwannoma indeed. She had transient dorsiflexion weakness, which the common peroneal nerve, I always tell my residents, doesn't take a joke. So even any manipulation of that nerve can give you a little bit of a neuropraxia. In her case, she actually received local anesthetic at the end of the case, which gave her a little bit of a temporary deficit, which resolved within 24 hours. She's back to ballroom dancing and sends me videos of her dancing. This is a 27-year-old woman with a history of NF1. She had developed right posterior leg pain, and she has an extensive family history of NF1. She did not have any neurologic deficits, but you could sort of palpate a mass within her deep right buttock, which you can see here on the coronal view, is quite a large lesion extending from the pelvis into the sciatic foramen and out into the right buttock and thigh. You know, given her history of NF1, you know, that is something we, as I mentioned before, take very, very seriously. She's a patient who I did end up getting a PET scan pre-operatively. And one of the pieces of information that are helpful off the PET scan are the standard uptake value. And if you have a max SUV score, typically over the range of 6.5 or 7, my sort of suspicion for MPNST is very high, but there's a huge indeterminate range, which unfortunately many of these tumors fall into. So again, it doesn't give you the best information pre-operatively. But her tumor was, you know, while she had pain in her leg, she didn't have all the red flags for MPNST. I went ahead and did this surgery as a combined surgery with my general surgery colleagues, where we simultaneously approach the tumor from the pelvis. You can see here the abdominal retractors, as well as the buttock in lateral position here. And it worked out very nicely because we were able to, the sciatic foramen was enlarged due to the tumor growth over time. And we were able to dissect the tumor en bloc. And so she had some enhancement within the pelvis that we will continue to watch. And her pathology, surprisingly, was totally benign, even despite the large size of her tumor. And so again, it just goes to show, especially with these patients, it is very difficult to predict preoperatively the precise pathology of their tumors, but sort of being prepared for a malignant operation versus a benign operation is critical, especially in these NF1 patients. This is another patient of mine who had developed right anterior thigh aching, cramping pain. You can see here her peripheral nerve sheath tumor was actually just at the level of the foramen. And again, small tumor, but you know, can cause significant discomfort when it's coming off the dorsal rootlets. And so we went ahead and resected that with facetectomy and resection of the tumor. I tend to follow these over time. Again, given their benign nature, her tumor ended up being a benign schwannoma. They tend to not recur as long as the tumor is removed completely. We do tend to leave the pseudocapsule of the tumor, which does enhance on imaging. So that's just something to bear in mind, that will typically enhance on your post-op studies, and that's just something I follow on subsequent imaging. So in general, with peripheral nerve sheath tumors, I think you always want to be thinking about the malignant potential of these tumors and be prepared for a resection that includes a a neurectomy, and sometimes bringing along colleagues in general surgery can be helpful for access and approach, particularly with these deep-seated pelvic lesions. And ultimately, these patients do quite well and are very, very thankful to not have their neuropathic pain that they tend to live with for before they come to attention. Thank you.
Thank you, Dr. Zarina. There's one question for you, I think, in the chat box. Do you also consider spine radiosurgery instead of fractionated radiation?
Yeah, that's a great question. I think it depends on the type of tumor. So typically when I have MPNSTs, we tend to like to do proton radiation for those patients. It has a great fall off, especially if I'm near the cord. And so that tends to be our preference. I end up working, I do gamma knife radiosurgery as well, actually, at my institution. So I end up working very closely with the radiation oncologists, and we've had good success with protons. In tumors that I'm concerned about regrowth, for example, we sometimes will cyberknife those lesions. I tend to not like upfront radiation in patients who have NF1 because they certainly do have a potential to undergo malignant transformation of their benign tumor. And so typically, you know, as is gold standard, we favor surgical resection followed by postoperative radiation.
Okay. I think, do you want to take through all the questions later? Because I think there are a few more.
Sure, yeah.
You can do it at the end.
Sounds good.
Yeah. Okay.
Sure.
So getting back on schedule here, we have Dr. Najia Elabbadi, who will be speaking to us on learning to mentor, which is an important topic in the current climate. She's a neurosurgeon at Sheikh Zayed International Hospital in Morocco. So thank you for joining us.
Excuse me, I just want also to emphasize that she is also, she's the head of the department in Hospital Sheikh Zayed, and also currently the president of the Pan-Arab Neurosurgical Society. Najia?
Yes, please, it's okay. You have everything is okay? You have the slide?
No, not yet.
And now? What happened? I share my screen. Yes.
Takes a few seconds. Yeah, that's on.
Okay.
It's okay?
Yes, it's
Perfect.
okay.
Okay, thank you, Souad. First of all, allow me to thank my dear friend, Professor Salman Sharif, and also all the organizing committee, especially Dr. Iqbal, for this kind invitation. And it's always a great pleasure to meet all of my friends, women neurosurgeons, even if virtually during this hard time. I'm seeing all of us, all of you doing well. I'm really happy for that. And I'm so honored to be able to share this wonderful experience with you today. So, okay. What is the mentor? Let me first to define what is the mentor and what is the mentorship. All of you know that the mentor from Homer's Odyssey, who has took care of Telemachus and the household while Odyssey was gone for 10 years to the Trojan War, and becoming the trust friend and counselor to his son. And we start by defining the concept of mentoring. I mean, what is the mentor referred to? The mentor is someone who gives knowledge, wise, trust advisor. A protege or mentee is the other person who receives it. And this process can be both professional and the personal. It can be also one-time contact or lifetime relationship, formal or informal. Okay, so it's important to know what the leaders, it isn't necessarily a mentor. This is very important to know it. A leader can be someone who we inspire to be like, to follow, as well described by John Quincy Adams in this slide. And when you become a leader, success is all about growing others. At that time, then you become a mentor. Let me share this citation, which always inspire me from James Keller said, "A candle loses nothing of its light, lighting another candle." And mentoring is a brain to pick, is of course an ear to listen and push in the right direction. So what worked for me was being that simple person they needed. They could count on our support on the academic, professional level, but as well as providing a personal support we never needed. So constantly I asked myself what kind of mentor I was to my mentees, and how to know if you are really a mentor. Understanding the mentor concept helped every time I respond to this simple concept. Was I just there to teach them, or trying to encourage them, understand them, and even show respect to their feelings and way of thinking? I knew I was mentoring them at that time. It was important to me to know if I was ready for this complex relationship by simply knowing I was offering them credibility, that emotional support, but also offering time and a flexible relationship. It's it's crucial for this for mentoring. So, of course, it required many outstanding characteristics. Among them, time, commitment, enthusiasm, altruism, career guide, to be as good as mentor, but also remaining to real person, to balance that personal to professional relationship. Here is what works and what fails with that relationship. According to my experience, it becomes successful when there is a reciprocity, mutual respect, clear expectations, and when the personal connection I talked about exists already. Once there is poor communication, lack of commitment, and personal differences, perceived some competitions or conflict of interest, it fails. And this is a study that was conducted, a wonderful study was conducted in 2013 by Strauss and collaborated, that confirmed those values that I speaking about it. So here are some of the most important characteristics of being a good mentor. We need to be advisor, credible, supporter, and insist on being truly interested in the mentee as an individual person. Of course, each relationship has its difficulties, and here is what to do when the gap is recognized or failure detected. We have to remain positive, constructive, use wisdom and the timing, and always avoid to criticizing, and try to remain open to mentees' opinions and, of course, their views. Here's some example of my mentees. The first one is mentees, but also one of my first patients as a young neurosurgeon, when I was a young neurosurgeon who had a complex skull base fracture repaired by myself at that time. And he graduated as an MD. He wished to pursue neurosurgery, but unfortunately couldn't do that. And we continue to be in contact till date. As I was progressing in career, I also had the pleasure to contribute as a lecturer with my with one of my great master, Professor Khamnishi, to train and mentor different residents from various countries in Africa. Here is the team in our program, WFNS Rabat Reference Center. Oh, the second mentee that I am really very proud, Dr. Derqawi, who is one of my protégés, mentee, protégé in French is more a French word, and the very first young and brilliant neurosurgeon to occupy the first position as General Secretary of the Moroccan Society of Neurosurgery only 1 year after his graduation. Now he is the vice president of our society, and he has been doing a tremendous job, even being at more than 2,000 kilometers from the capital Rabat, and where he practiced at the, for 4 years, and now he works in my department in Rabat from 4 years ago. This is another example, but a wonderful example and beautiful relationship mentor-mentee is Claire Karakizi. She is from Rwanda. 2 days after brilliantly passed her board exam to be certified as a neurosurgeon, she took off to Boston for a 3-month fellowship sponsored by WNS and spent a month with Professor Isabelle Germano in New York and 1 year with Professor Gentili in Toronto, where she was given a clinical fellowship position among thousands of brilliant applicants. Beautiful example of mentee we are all looking for. Currently, she back to Kigali in Rwanda. She was practicing neurosurgery in military hospital, and she is the first woman neurosurgeon in this area in Africa. The last example, because we have not a lot of time, my youngest mentee who also chose to become a neurosurgeon, and she's here in the 4th year now. Hajar is following the step of his senior and sister in the field, I mean Claire, and the two already established this interesting small mentor-mentee relationship. At last, successful mentor-mentee relationship continues through life, continue outside the professional or academic assistant. Mentor and mentee can be close friends, make travel plans together. You can, they can also be co-author publication and co-presenter of conferences. We need to assist them on applying for foreign universities, seeking appropriate graduate programs, finding scholarship, applying for jobs, etc. So my final thoughts has to be productive, creative, but don't forget it's supposed to be fun for always fun for the mentee and the mentor. And the heart of mentoring, as was said wisely by Gandhi, and all of you know that, especially in this area, the best way to find yourself is to lose yourself in the service of others. Furthermore, not to all women neurosurgeons, a good neurosurgeon has the eye of an eagle, the heart of a lion, and the hand of a woman. Thank you so much for your attention.
Thank you, Najia. I think that Dr. Sandi Lam is with us now. Yes, she's here. So after this very beautiful presentation about mentoring, which is very important in the field of education, we will have also another interesting presentation by Dr. Sandi Lam, which is the Chief of Pediatric Neurosurgery in Chicago. And of course, she will talk, as I said, about a very, very important aspect, which is how to manage a career. So Dr. Sandi, it's you. Are you hearing me?
I am, and I'm going to share my screen. Let's see if it'll let me share. Okay. Okay, well, thank you so much for inviting me to join this wonderful group. I'm really glad to be the last talk of the day because this really highlights the group of incredible people doing incredible things. So, you know, in career development, it's not just, you know, your career, right? It's actually defining why you're here, you know, why you get up and go to work and put in incredible hours and dedicate your life. And when we look at traditional education and training and kind of, you know, what we look at when we're going into neurosurgery is, you know, you have education, then you have the training process. And if you're lucky, you find incredible mentors like Najia, and then you become a faculty or an attending and a consultant, you get a job, and then you kind of expand your impact in the field. But I would actually argue that the world is actually becoming more connected. And when you look at the rise of social media, the way that we're all communicating with each other around the world right now, actually is incredible. So I would think that actually everybody can start contributing now. Neurosurgery does require a lot of knowledge, skill, rigor, and really years and years of training. There is a rich legacy and there is a hierarchy. But yet we all know the more and more we get into it, there's so much more to discover and so much more to improve. So I would actually look at it less of it as a linear journey and look at it as something that is feed forward. The mentors are always learning from the mentees. The mentees are always trying to grow, but also really push us as mentors to think about what we're doing. I guess I don't know you guys all very well, but here I'm going to share. When I looked at what I thought I had to share about career development, I thought maybe I might not, because I can show you this is my timeline. I was a political science major. I worked in a startup. I didn't go to medical school till later, and I was going to hide it, but I'm not going to. I actually went into orthopedic surgery first. Later on, I switched into neurosurgery after I realized they were better surgeons and better doctors, and really cared for the sick patients and you know, always did the right thing. And just like the mentee story that we just heard, we really have those types of stories that really have a profound effect on my life and other people's lives. And then in neurosurgery along the way, a lot of mentors and mentees, and collaborating with colleagues from multiple spheres, not just neurosurgery, but in business, in law, in engineering, across specialties in neurosurgery. And now, you know, when I look at, you know, what the next steps are, it's still fundamentally trying to make the most of every opportunity to learn, always trying to do a good job, always doing the right thing and helping people, and really just trying to make the field better than the way I found it. And if that is, you know, by being on the editorial board of JNS Peds, or you know, training fellows, training residents, contributing to the future of the field, all of that is kind of fair game. So, you know, things that I wish people had told me along the way. And this goes on to the kind of linear nature of how how education was set up, right? So you do a bunch of exams. You hope you get picked for the next step, right? Whether that's university, medical school, residency, and then fellowship or more training. And then at some point, you get a job, and you get more jobs, and you grow, and you join the organized neurosurgery, and you really make more and more of an impact based on kind of where you are and the roles that you have. But I would argue that in the field of education, we are not very good at training our residents and fellows to go out and negotiate for jobs and really define what they're about and how to actually set themselves up for success. So I would say that's one thing that we should think about, how to kind of shift that focus, from kind of pick me to, what am I about and how do I bring value to the team, no matter how old I am and no matter where I am. And that's why I would encourage everybody to define your why. And think about your purpose in life. And this might sound a little cliche, but I think, when you have a hard day in surgery, when you have a hard day in residency or as an attending, I think remembering what inspires you, what you're about as a person, what you really bring, that's very unique. And when you look back, how you think you want your life to be measured, I think is a very powerful thing for day to day and also kind of guiding your career trajectory. So in residency, I always heard that, this is, it'll get better someday, but actually this is someday. This is a part of life. This is, your youth. And I think it's really important to remember, not to have kind of deferred gratification. And just remember, this is someday. It's the best time to learn, see what works, see what doesn't work. And you always have the choice to act in your own value system with kindness and with reason. For fellowship, try to learn all the things you didn't learn as a resident. Expand your network, look for these role models and mentors. And try to see, how you're going to, meet colleagues in the field and make those connections that are going to be your friends and your colleagues for the rest of your career. Learn how to run a practice, but also how your role models live their lives. Then when you're an attending, I think we can have a whole talk on negotiation, but really when you look to see where you're going to set up your life and your career and your family, your employer should actually want you to be successful. It costs a lot to recruit and replace. But, if you know your why and what you're about and what you bring to the team, I think that is a good place to start. And you may not know exactly where your career is going to go. I did not, but we have amazing people to look up to. Even today, we have great examples. I mean, Dr. Abhidha Shah's dissections were amazing. Dr. Zarina Ali's peripheral nerve cases, Maya Babu's neurotrauma experience, Aneela Darbar's endoscopic experience, and then Najia's prominence in the field and also remembering to lift others up. So it's okay to just look for opportunities when you first start out, but then look to take advantage of those opportunities if you know what's important to you. I also agree mentorship is wonderful. It really goes both ways. The mentee and the mentor takes a lot out of that relationship. My last slide, moving onwards, no matter what, it takes 10 years to build a reputation, I've heard, but it really takes only 10 minutes to destroy it. So live every decision and every moment and every day to your values. Remember your why and live your best life. And remember, we rise by lifting each other. And I'm really glad to virtually meet this community. And please feel free to reach out to me if you have any specifics, or I can put you in touch in any way with anything.
Terrific talk. Thank you, Dr. Lam. I think those are principles we can all use at different stages of our careers. Well, that concludes the session. Dr. Noor, any chance that we have a few minutes for going through any questions, or do you want to do that offline?
Yes, it's fine. I think, sorry, I'm just sending in here. We can have few questions, it's okay. The other thing we can do is ask Dr. Souad Bakhti to say a few words.
Thank you, Professor Salman Sharif. Just to say that we have had a wonderful session, very beautiful talks, very interesting talks about scientific topics, and the two last topics about education. And as I said before, I'm very, very proud because it's exclusively a webinar, which is with speakers totally women. And I hope that in the future, we will have more and more webinars like this, and to show that maybe the future of neurosurgery are women. So thank you, Professor Salman. Thank you for all what you have done. Thank you for the organizers and the speakers.
Thank you. Thank you for the moderator.
Any questions anybody wants to ask? Yeah.
Please, can I have just one comment and maybe one question for Aneela? And first, I would like to congratulate her. Her great work, really, Aneela. It's a nice presentation. And my comment is about the consistency of colloid cyst in many cases. Maybe it's sometimes it's not be easily aspirable, and may author advise to decompress at least the foramen marrow and coagulate the plexus colloid for for not the persistence or the progression of hydrocephalus. And sometimes when you are, of course, removing the cyst, some pieces can go through the aqueduct sylvius. And in these cases, some authors did VCS in the same time. And what do you think about that? And the last questions is, according, I just, yeah. Can you just answer to this question?
Thank you, Najia. So usually, most of the time, whether the colloid cyst is large or small, the choroid plexus actually sits on top of it. So the first part, before you even start removing the colloid cyst, is actually to coagulate the choroid plexus. And I usually do with a very low current monopolar. And when you coagulate the choroid plexus, then you're actually able to see the cyst wall underneath it. And you are absolutely right that once you open the cyst wall, many of the time, I would say at least 20% of the cases, the contents are solid and they are not easily aspirable. So I had shown you a case in which if a colloid cyst is small and the contents are solid, you try to aspirate it first through a suction. And if you can't, then you actually can use any kind of instrument to grab the solid tissue out. And if you think that it's not possible, you can always convert it into an open procedure. But my style of removing it, the first I coagulate the choroid plexus, then I open the cyst, try to suction the contents. If I can't, then I use the instruments. Now, your second question is about that what if you plug the aqueduct with one of the cyst components? So I have seen some aseptic meningitis happening in these patients because some of the contents actually spill in the ventricles. And if that happens, it usually clears up very easily. What I do is after removal of the colloid plexus, I actually keep the EVD in for a couple of days. And then I just close the EVD and just make sure that the patient is okay, and then I actually send them out.
Okay. Professor Souad, I saw Professor Azhari who hand. He would like to ask something maybe.
Abdul Samad Al-Azhari, you're unmuted. If you want to ask a question, please go ahead.
Thank you everybody, and thank you for the WIN, the president of the WIN, and all the topic was really very interesting. Since the mentor with the velvet hand of woman of Najia Elabbadi to the anatomic region with Abhidha Shah, thank you and congratulations for this webinar. It was really very interesting. I have just one question for Abhidha, Shah. First, congratulations for really very nice anatomic topic. My question is, we know that limbic is all the area, but with you explain it very well. My question is the external olfactory tract is normally going to the hippocampus. So when there is some epilepsy with the sign of olfactory, the explanation is that is some fibers going to the temporal lobe, and it's temporal epilepsy, the name. I think it's there is the 3 tracks of olfactory, one medial, one internal, and one external. Which one you can identify it as structure of limbic or all? And my second proposition is really interesting to make this course of anatomic for resident. It's really very interesting because it making the mind, the structure of all the brain, and the surgery should be identifying all these structures in the mind before going to the surgery. Thank you very much.
Thank you, Professor. So to answer your first question, the lateral olfactory part, the lateral olfactory striae, that connects to the hippocampus. It goes above the anterior perforated substance and it ends in the entorhinal area. From the entorhinal area, there are 2 tracts. There is an alveolar tract and a perforant tract. Both of these go to the hippocampus, one from the medial aspect and from the ventricle. So that is how they reach the limbic system. From the medial olfactory striae, they go to the septal nuclei. Now the septal nuclei is part of the paraterminal gyrus. So that connects through the striae medullaris to the habenular nuclei, which again connects from the indusium griseum to the septal nuclei. So it's a very beautiful circuit. They are all interconnected. And if you really see the anatomy, then you start enjoying and understanding it better. So that is one. And second is, yes, residents are welcome to our department. We have these courses, we have specimens available. And I do the dissection on a regular basis because I just like doing it. And obviously we teach them. All of our residents are also involved in the dissection, and anyone is welcome to our department in Mumbai, and it will be great to have them there. Thank you.
Thank you. Just to add to Abhidha, I was just telling her as well, we have started these Roton anatomy sessions for trainees, and generally we have about 300 participants in each of these webinars that we're doing. And we have just, we are on finishing the ventricular anatomy module, which we have the last one next week. And I think after Eid, we're going to start twice a week webinars, and the first one is cerebrum. And I was saying to Abhidha that she could join us. Azam joins us from Wisconsin, and we have Hassan Syed as well joining us from Virginia. So I'm sure all of you can contribute and help the trainees to learn, and we all can teach each other. That would be great.
Yes, that would be great. That would be great. Thank you, Dr. Sharif. That would be great.
And we have Anwarul Haq who wants to ask a question. Yes, Anwar, please carry on. Anwar, you want to ask a question? Okay, I think he's disappeared on us. And we have Said Ben Ali. Yes, please.
Good morning, everyone. Thank you very much for all the speakers for their outstanding lecture. My question is about brain mapping and the wake surgery. For Professor Shah, I think it's difficult to test or to monitor the limbic system during this surgery. What do you think about this? Can we monitor some aspects of this limbic system during this kind of surgery?
I'm not sure, because the main component is emotion. And already when the patient is undergoing an awake surgery, there are too many emotions in play. So I'm not sure what we will be able to map, but it is worth considering. Maybe we could try memory by mapping, something about recent memory. I'm not sure if it will work, but that is what I thought about. Maybe we could just test memory. Emotion will be difficult to test because already there are too many emotions in play during awake surgery.
Okay, I think we're going
Professor
to...
Salman, please,
Yes.
could I just have just a comment with Abhidha about that?
Yes, yes.
Abhidha, you say it is, yes, I totally agree with you about emotions, but what about what is saying Professor Dufault, who is now looking for mapping the emotions? What do you think about that?
Yes, I mean, this is something that if we could achieve, it will be a very, very thing. And yes, we should venture into it. I'm not sure how it will work, but yes, because there are really too many tracks into play. It's not just one area, just the temporal, because you have the cingulum that is connecting to the frontal and the parietal cortices. So how will we be able to localize it to one will be an issue, but it is worth considering and worth looking into, definitely.
Totally agree with you.
I think we'll wrap up. It was wonderful. I'd just like all of you to say a few words before we just close this session. So we can start with the senior most and go on to the junior most.
Okay. May I have taken
Yes,
just I have a thing to remember to all women neurosurgery. It's important testimony given by one of famous and well-known neurosurgeon, Professor Spetzler, and the white paper, which is elaborated by WINS, Women in Neurosurgery from USA, which he proposed a strategy to promote women in neurosurgery and also to promote those female neurosurgeons to higher responsibility position, both in organizing and academic neurosurgery, to help address the lack of women in neurosurgery. We need he proposed to follow 4 strategies. So I recommend it to all of you to read this paper. It's very, very interesting. Thank you. And thank you all for all the speaker, and especially for my friends Souad and Salman for this great webinar.
Dr. Bakhti, you, please, a few words. Just wrap up.
I think I've talked a lot, and so maybe Aneela or the others can give short words. Of course, I agree with Najia.
Okay, just no, carry on. Don't worry about this. This is Imad, my secretary, is just making sure that everybody knows what we have next lined up for them for next week. Sorry, I'm just going to go through this and so that he can remove this. This Rick Fessler is there talking about complex surgery of cervical spine, and joining him would be Maurizio from Milano, and Mehmet Zalili, who's the chair of the spine committee, will be moderating this session, and we have this on Monday. I think that's what he's showing us for time being, but no worries. So please carry on. Sandi, where are you?
I'm here.
Yes, a few words, yeah.
Oh, this was just a wonderful showcase of talents and really people really dedicating their curiosity and their interests and putting in that work. I know it's so I grew up in Hong Kong and I happen to be working in the United States. So there's always this kind of cultural tension where I think it's weird when people just say, oh, follow your passion, right? Because I mean, we all know, everybody in this audience knows that it's beyond passion, right? It's obligation, it's suffering, it's sacrifice, it's doing the work that nobody else really wants to do, but we do it because we have to, and it's the right thing to do, and we know we're going to do it right because that's how we're built, right? So I think it's beyond passion, but I think that everybody speaking today really highlighted that dedication, that culmination of true work and rigor and everything that encapsulates being a neurosurgeon. So, you know, my hope is, you know, eventually we don't have to say a female neurosurgeon or a male neurosurgeon. We're all neurosurgeons, and we are all making the field better. And I truly believe that. And thank you for putting this together today, because this really shows that we're all working to make this world and this neurosurgery world a better place. So thank you.
Thank you. And Maya, are you there?
Okay.
Maya, are you there? Take a few words.
Yes.
Yes.
Nothing really. I just wanted to echo, thanks so much for this opportunity. And if there's any questions, please feel free to reach out to me afterwards. Thank you.
Thank you. And Zarina?
Nothing else to add, just that I'm really excited to be part of this amazing community, and again, available to answer any questions. I know there's a couple of questions about peripheral nerve surgery. Feel free to reach out to me and keep up with all the great work that everyone's doing. It's terrific.
And Noor, where are you hiding? Is Noor there somewhere?
Yeah, I'm here.
So just a few comments before we close.
No, I would like Professor Greg and Dr. Hassan to say a few words on my behalf.
Okay, all right. Greg?
I have to unmute him. Yeah. Yeah.
I didn't think I was going to speak today, but
I have to make you speak.
Noor, who I've known for a lot of years, and I've made several trips to Pakistan over the years, and she's always made sure that we were well taken care of, and I congratulate her and all the presenters on really a very nice group of talks. It's a little bit early in the morning here in Wisconsin, and it's pouring rain out, but I apologize for my dress. This is just how I dress at home, and those of you that know me just know that's sort of my attitude. But I think the comment that at some point when we can stop saying women in neurosurgery and men in neurosurgery, that just becomes neurosurgeons. I think it's a very poignant comment. I will also mention that WINS, at least I just finished up on the AANS board, but WINS is going to become a separate section. So it's going to be its own joint section. So there's even more focus on it. But thanks for asking me to at least be along and watch this.
Always. And Dr. Hassan? Is he here?
Hey.
Yeah.
Hey guys. But I really enjoyed listening to everyone. And to Jersey.
I think can't hear him.
Greg, what did you do to his Wi-Fi? Okay, guys, I think Hassan, I think there was some problem with Wi-Fi there. I thank everyone. It was brilliant. And Noor, you want to say a few words before we wrap up?
No, I'd just like to thank all the speakers. I know I contacted most of them like in 3 days, and everyone responded really well. Thank you for showing up and moderating, especially Dr. Souad and Dr. Zarina on such a short notice. I hope we can have you guys on board again soon. And I think this was just a start, and I think we'll have more seminars like these throughout, hopefully. Dr. Salman?
Yes, why not?
Yeah.
No problem.
Yeah. All right.
Okay.
Thank you guys for all coming
Thanks,
here.
everybody. Bye-bye.
Thank you.